Morning, good afternoon, or good evening to all of you, depending on the region you are. Welcome to the World Family Doctor Day webinar hosted by WONCA Working Party on Planetary Health. And first of all, happy World Family Doctor Day to you all. So, as you know, 19th of May is celebrated every year as WONCA's World Family Doctor Day. And this year, dear colleagues, the theme of the World Family Doctor Day is compassionate care in a digital world. So, celebrating the World Family Doctor Day while celebrating our patients and also understanding the importance of digital health to our day-to-day activities, day-to-day patient care, while keeping the compassionate care we provide as family doctors is very important. And that's why we are here today. And in addition to that, the care we provide to our patients, their families, the communities, and also the planet. So, how the digital health has its impact to planet, and also how we are going to maximize our care in this digitalized world while we are caring for planet as well. This is our theme today. So, WONCA Working Party on Planetary Health hosting its webinar under the theme of Caring in the Digital Age, Compassion for Patients, Systems, and the Planet. So I welcome you all, dear colleagues, and also I welcome warmly our speakers. We have Gabrielle Samuel and also Claire Brockbank. Gabrielle is our guest today. She's from the UK and she's a lecturer in the King's College London. And Claire is of one of us. She's the Africa lead of WONCA Working Party on Planetary Health. So the first talk is from Gabby. The title of the topic is the hidden environmental impact of digital health. Gabby will introduce herself, so I'm not going to tell anything else. Over to you, Gabby, to go ahead and tell us about the impact of digital health to our planet.
Thanks so much, and I'm delighted to be here. I take it you can hear me okay, but if you can't, I'm sure you'll scream out. So I was invited to give a talk on the hidden environmental impacts of digital health. So if there's aspects that don't necessarily relate to care and compassion, then I feel that we have a lot of time at the end where we can actually open up and see how we can think about these types of issues in relation to care, and in particular compassionate care. And I've done some work around this outside of digital health that might be able to feed into those discussions. But before I do, I wanted to tell you who I am, who is speaking to you, because I think that's really important in you kind of understanding where I'm coming from. So my background is in the life sciences. I have a PhD in genetics, not human genetics, but genetics nonetheless. Worked in lab-based genetics for a while before I switched over and did a master's in bioethics and biomedical ethics, medical sociology. And ever since I completed my PhD in that over a decade ago, I've been interested, surprisingly enough, in the social and ethical issues associated with genetics and genomics. That expanded as genomics became big data into biobanks, which expanded into digital health, which expanded into AI. And about 6 or 7 years ago, before anybody was talking about the environmental impacts of digital health or digital infrastructures in general, I noticed that they weren't being discussed in the ethical literature around digital health, or in the healthcare setting at all. And so that's where I've been sitting for the last 6, 7, 8 years. The types of questions I ask. So I'm telling you this because you might want to come back to it in our question and answers. Our questions around justice, datafication of data, ethics, responsibility, values, systems thinking, and so forth. Okay, and we set up, because there was so little work looking at the intersection of digital technologies and health and the environment, we set up a Shade Research Hub with my colleague, Federica Lucifero, who's at the University of Oxford. And here we use it to conduct research, very interdisciplinary, which is really important to us, with clinicians and computer scientists and social scientists and so forth, to really explore the dimensions where that intersection occurs. So, what I wanted to talk to you today about was to argue that we have a moral obligation to consider the environmental harms of healthcare. Um, when I say argue, I think that that is problematic in and of itself, but I'm going to take that as a consensus. And then show you that digital health offers a useful way to do this, to address this obligation, but that digital health has its own environmental harms. Right at the very end, I'll talk about some open questions about what that means for us and who the us is and how we should think about these questions. But then what I'm hoping to do is that that will raise many questions that we could get into a discussion about afterwards. So, the moral obligation to consider the environmental harms associated with healthcare, more generally, have kind of exploded in the literature, in the ethics literature over the last maybe 5 years. And they're based, if we want to go back to basics, the first question we need to ask is, why do we have a moral obligation to consider environmental harms? And that might depend from person to person, but we can split it into two different categories. So you might think that it's important because you are an ecocentric person, or the fact that you believe in ecocentrism, which means you believe that the environment has moral worth and that that moral worth is distinct from any form of human worth. So if all humans on the planet didn't exist, there was still an environmental worth that was associated with the earth. And sometimes if you haven't thought about this before, you might not be sure. You may think you're ecocentric and then try out some thought experiments and realize maybe not, maybe I don't think the environment has worth in and of itself. What you might feel that you sit more comfortably with is an anthropocentric approach, which views the environment as not having any moral worth, but only humans having moral worth. But then what you believe is that because the environment and the humans are connected or interconnected, that we need to protect the environment because it affects humans. You may, but probably not if you're on this call, believe that environment doesn't have moral worth and that human health and environmental health are not connected, such as some people like eco-modernists might have you believe, in which case you would probably not think we have a moral obligation to consider the environmental harms of healthcare. But I'm assuming that nobody on this call is that. So you are either an ecocentric or an anthropocentric that recognizes the link between human well-being and the environment. So that basically means we need to think about humans or the environment in our decision making because it has moral worth. So then the question is how ought we do that? And this is where, if you go into the literature, you'll see just a huge plethora of literature. So some may argue that we need to consider it because of environmental justice issues. So these will be anthropocentric people because environmental justice is based on social justice and about the inequalities between the benefits and harms of environmental products of technological society. And you'll see this in sociological and advocacy literature and political philosophy. You may see other notions of justice, so intergenerational justice or ecological justice. If you're an ecocentric, maybe ecocentric justice, so that therefore, or ecological justice, so that we need to consider the harms to the environment over human benefits. You may be religious, and so you may believe that we need to protect the environment based on stewardship, or you may be a public health advocate, so you may align with maybe Planetary or One Health. Or eco-sociality. You may be working in global health, in which case environmental determinants of health may be where you sit, or you may come from indigenous perspectives, in which case traditional ecological knowledge or various indigenous perspectives. Or you may be a feminist or an ethicist, or maybe potentially for you, if you're primary care, then the do no harm in medicine may stand out the most to you, and where that harm is considered much more broadly. And so, in these kind of perspectives, that they will all kind of lead you to different conclusions about how we should deal with the environmental harms. And on top of that, there are these other factors that we need to consider. So, how do we consider these environmental harms of, for example, distant humans versus present day humans versus the patient in front of you? How do we consider these harms against social justice issues that may be relevant in your practices, or against the social value that's associated with the health work that you do? So this is kind of the literature that thinks about the moral obligation to consider environmental harms. And then in a digital space, the argument, there's been this increasing argument in the policy area that digital transformation is a really great way to address these environmental harms. Three main rationales can be pulled out. So one is improving the operational efficiency of existing healthcare infrastructure. So sensors for lights, controlling room temperature, forecasting resource use, so only necessary supplies are purchased and so forth. The second is applications and or services with lower environmental impacts. So that's, for example, virtual visits versus in-person visits, or replacing paper records with digital electronic health records. Or finally, keeping the population healthy to reduce the demand for healthcare. And this is, for example, using large databases and AI algorithms to support improved clinical decision making and patient interaction. So here's a diagram which basically shows what I said, which is where digital technologies can be incredibly useful, increasing the efficiencies of healthcare systems, which leads to less demand on the health system, therefore less environmental impacts. And also less environmental impacts might lead to improved health outcomes because of the relationship between human and environmental health, which then leads to less demand on the health system. And then at the top right, you have prevention as well. So using data and AI to drive prevention, which also leads to improved health outcomes and less demand on the health system. And there's preliminary evidence to suggest that this is actually happening. So there is, for example, effective remote real-time monitoring of patients, which means that patients don't have to come into the clinic as much, which reduces, for example, transport-related emissions. So these are just some examples of where it has been affected. A lot of it is promissory, but that there is this evidence that this effectiveness is being shown, at least in small scale. And so it suggests that digital health is this useful tool for prevention and decreasing the environmental impacts of healthcare. So we have this win-win situation that's going on. At the same time, it's important to remember that digitalization could reduce environmental impact, but it's possible that these technologies may be implemented in ways that don't lead to reductions or may lead to increasing resource use and other injustices with little change to health outcomes. And that's what I want to move on to talk about now. So we know that there's been this huge growth in digital infrastructure. This is an example. I just pulled this off the internet today to show you the increase in the amount of data that we have in the data sphere of the world. So we're up to, I think last year, 175 zettabytes, with 1 zettabyte being equal to 1 trillion gigabytes. So we have massive and massive amounts of data that we are collecting and are continually collecting. Digital health is no exception. It is actually the fastest growing industry in the data sphere in terms of the amount of data that's being collected. So we don't need to look far to look at technologies such as, for example, top left, digital twins, where we're collecting huge amounts of data to develop these digital twins that we can hopefully help against more invasive surgery or other kind of technologies that we might need to use. Digital devices and sensors. So we're sensing our bodies a lot more. This is particularly in high income countries, but is increasing in lower middle income countries. So we're seeing this move to personalized medicine. We are collecting huge amounts of data through biobanks. So UK Biobank is the probably one of the biggest biobanks in the world. So it collects data on 500,000, well, it has collected data on 500,000 UK citizens, and it's actually still increasing data and collecting more and more data. And even they're moving now to this real-time data. But biobanks are opening up and databases are opening up all over the world in many, many nations. And then we're increasingly using AI and machine learning and computer vision and deep learning to help us with analyzing all of this data that we are collecting. This is an example from the UK National Health Service, which is, well, as it stands, our National Health Service. We are collecting huge amounts of data from there. So Spine, which is the kind of software that it's moving to, which supports the IT infrastructure for health and social care, and this is just in England, is joining over 44,000 healthcare IT systems. And it handles over 1.3 billion messages a month. And at peak times is processing more than 3,200 messages a second, not including all the data that we're collecting from patients that come to healthcare all the time. At the same time, we know that all of this digital infrastructure, all this data doesn't exist out there in a cloud, but it's material. It has a digital infrastructure that is physical and material. You can see on the left-hand side at the top, the inside of a data server, the data centers where all of this data is collected, which is just rows and rows of computers. The bottom left is a hyperscale data center, one of the really, really massive ones that are like kilometer long because they're so long, that just has rows and rows of computers. Top right is the underwater cables that are connecting us, which without we cannot speak to each other or be having this meeting. So you get the idea of the physicality. The environmental harms that are associated with this digital infrastructure are throughout the life cycle. So from mining rare minerals, which ethically in and of itself is not morally problematic, but the way in which we mine exploitative extractionist practices is. Through to manufacturing, and there's huge numbers of environmental justices that come from the hazardous waste produced by manufacturing digital technologies across the world, and right through to the energy and water use from data centers, and then the electronic waste that is left right at the end when we finish with the computers, which we often recycle very, very often within the space of 2 or 3 years. And that electronic waste often ends up in low middle income countries for a whole range of very complicated political reasons. And it's not always recycled in appropriate ways. But at the same time, what it means to recycle appropriately is problematic in and of itself because of various regulations and inequities that may emerge from there. So that's kind of what we have to think about when we're thinking about, our digital health and the background behind it. This is just a really nice cartography of Gen AI, but it stands for any digital health. The key takeaway is look how complicated the life cycle is and how much physicality is taken in from the life cycle of developing the digital hardware so that we can collect that data. So there have been many frameworks and guidelines and carbon calculators that have been developed to help us think through the environmental impacts of the digital technologies we use. These are very often just based on the use of the digital technology, so not the downstream and upstream issues. So, for example, developing calculators that show you that if you have a virtual care visit, that reduces emissions because somebody doesn't have to drive to hospitals for that appointment. And then there's a lot of work around how you balance that against fairness and equity in terms of the patient's preferences and expectations and interests in terms of whether they want a virtual care appointment or an in-person appointment, and how you keep the patient at the center of these shifts to the environment and how kind of balance patient care and equity and so forth. So there's a lot of work that's going on around that and these types of tools. At the same time, these tools are very reductionist, and we need to be aware of these reductionists. So the picture here, which is the blue squiggly line, is if you're trying to sort out what to do about the environmental harms of digital infrastructure, beyond just measuring one specific instance, such as I didn't drive to the hospital on that day, so I can calculate my emissions saved. And this is because of the rebound and revenge effects. So, as the data sphere grows, what happens is we're collecting more and more and more data. And the reason we often do this is because digital infrastructure becomes more efficient, as does the software that's used. And the problem is that because we're not constraining our behavior as things become more efficient, we change our behavior um, in response to that efficiency, which leads to less energy savings than we expected. And in worst cases, it backfires, leading to rebound effects. So this would be the example of me interviewed, which actually happened. I interviewed a population health AI researcher, and I said, "What would you do if, AI models became more efficient?" And he said, "I would run bigger models." For you, you might want to compare it to, for example, buying a more energy efficient fridge and then feeling that that's okay because we can open our fridge more often because it's energy efficient, or you can use the savings to fly somewhere. So these are the types of effects that we are much more messy. They're not as easy to measure. I put cleaning park benches there because Anne Marie Moll gave this great example of an example in the Netherlands where they tried to um, reduce environmental impacts by shifting from cleaning park benches with chemicals to cleaning them with a really like a jet spray, a hot water jet spray. But the problem is when they did this, all the paint of the benches came off and flew out into the greenery around, raising an unintended consequence of that move to trying to be more environmentally sustainable. And so these types of revenge effects and rebound effects become really complicate how we think about our responsibilities and obligations when we're thinking about addressing environmental harms, because they go way beyond our clinic. And to try and address these issues, some scholars talk about efficiency not being enough. So it's not just that we have to think about how to make our resources more efficient, but the sustainability aspects require two more things. And this is in the broader sustainability literature. So one is consistency. So this is just changing something. If you have a goal to get somewhere, you can make a change in terms of how you get there by choosing something that's less environmentally harmful. So, for example, using renewables instead of fossil fuels. So, putting all your data in a data center that is powered by renewables versus fossil fuels would be an example of a consistent practice. And then the other one is sufficiency, which is very interesting. We can divide this into digital and data sufficiency. So I'd say digital sufficiency is like hardware. So reusing hardware, sharing hardware, reducing e-waste, all of these types of things, which seem a bit more easy. Where it gets more complicated is when we think about data, because then it's asking us that we should only collect enough data for what we need, because therefore, if we have made something more efficient, we don't then go and collect way more data because it is efficient. We only collect what data is sufficient. But only using enough data that is sufficient is really complicated because it we often live in a world where the accumulation of more and more and more data is seen as something that is going to improve health. So we see health outcomes as improved if we can collect more data. But what I would like to argue is that this often narrows what being healthy means. So it basically promotes the idea that better outcomes can be equated with better monitoring, analyzing, assessing as much of our lives as possible. And with such a fixation on the need for data to improve health, it's sometimes really easy to forget that the very act of data accumulation and analytics cannot and will not produce health benefits on its own. And this is really important because often, and I don't know if any of you have experienced this at all, if we move towards more data, it can also detract from experiential knowledge. So, for example, if you're sitting in your practice and you've had to look at data more than you looked at like the patient in front of you, and what that means in terms of balancing the data, which might be useful, versus the person that's in front of you. And where the amount of data is enough for you to be able to make a judgment call so that we don't become almost de-skilled because we're only relying on the data. And it's also really important because when we focus on data too much and the digital health too much, it detracts attention from the need for other measures. So promising that data is going to improve health outcomes ignores the fact that we already know how to improve health outcomes, but we have socio and political social and political contexts that don't allow us to do so. And that's what causes the inequities. So, for example, we know that investing in education and welfare will improve health outcomes, but in certain nations, we don't necessarily do that. But what we're doing is promising that we'll collect more data and that will solve our issues. And so that becomes quite complicated when we start to think about data. And the argument here is that if we're just collecting data and it's not going to improve health outcomes any more than if we didn't have that data, then you have that idea of wasted resources. And so, just finishing up, this leads to a whole bunch of questions around responsibilities. So, we might have a moral obligation to address the environmental harms that are associated with healthcare, including digital health. But what does it mean, especially for the really hard questions? Like efficiency is a little bit easier. So, the question is, do we have a responsibility? Like, who is the we in this? So, is it the same we if I'm in the UK as is in Botswana, or if I'm in Mexico or any other country? How is the meaning of environment affected when I move between those countries? And is the environment as much a priority as direct health in each of those countries as we move through? And we've done a bunch of empirical research which suggests very much that's not the case. And so that we, who is the we, is really important. And it also relates to who is the we if I'm a primary care practitioner versus if I'm a we an institutional manager versus the we as in am I a technology, data center manager. It also relates to the question of responsibility. So Donna Haraway argues that we need to think about responsibility as a hyphen. So response able. I need to have the ability to respond. So if there's not much I can do in my practice, then I'm not able to respond. And so the question is what am I able to do? What am I not able to do? And consider agency in that respect. Other questions relate to whether healthcare should receive a free pass, and I would argue against that. Please ask me more if you want. And also the idea that if we put too much responsibility on primary healthcare, or individuals or doctors more generally, then this sits within neoliberal notions of governance that distract from social political issues more broadly. And then finally, like, what should we do around questions around rebans? Are these small changes futile? And how can we consider questions of data sufficiency? And what does that mean in practice when we're thinking about our own patients? And so I would argue that we need to conceptualize our responsibilities in terms of collectives, in terms of citizens, and I'm happy to talk more about this. But collectives need to be seen as more than the sum of individuals. So it's not necessarily about reducing our environmental impact, but it's more about advocacy and developing collectives around the topic. So, for example, coming to the seminar today or listening to it online, being part of something, and also asking questions. So we developed this green digital health tool, which helps digital health practitioners think about the types of questions they would need to ask if they wanted to think about environmental harms. A lot of it is around just ask the question, because by asking questions, it drives people to build awareness around the issue. And that might be as much as response able as you're able to do. I think there's some interesting questions around citizenship, but I will stop there. I'm pretty sure I'm out of time. Here are some references. Thank you so much.
Thank you very much, Gabby. I think that's a very interesting talk. And when we are talking about we also think about our patients, not only the doctors or the practice managers and so on. But thank you for that interesting talk and a lot of things to think about. But we'll elaborate on certain things after the next talk. If you have questions, colleagues, we can put them on the chat. But let's go to the next talk. For the moment, the next talk is Compassion Beyond the Screen, Caring for Patients and the Planet. So we have our colleague, Claire Brockbank, who is also WONCA Working Party on Planetary Health's Africa lead. Claire, who worked as a general practitioner in the UK before moving to Gaborone, Botswana in 2012, where she now lives and practices. She's the chairperson of Botswana Association of Family Physicians, and also, as I told, is very active in our working party. Dr. Brockbank also serves as the co-chair of the 9th WONCA Africa Regional Conference 2026, which will be held soon in September. Claire is a passionate advocate for strengthening primary health care, preventive lifestyle medicine, and effective multidisciplinary healthcare teams. Over to you, Claire, to go ahead to talk about the compassion behind the screen.
Thank you, Sankha. Can you see my screen okay?
Yes, it's visible.
Okay, great. And thank you for the introduction. So today, when we're celebrating World Family Doctor Day and compassion in a digital world, I really thought we should think about our role as family physicians, and that we are quite pivotal in helping our patients navigate their health journeys in an increasingly complex world with the advent of AI, new technologies, information overload, amongst other things, and rising problems that we have with climate challenges. So I thought I would really share my lived experience of digital health. I am no means an expert in digital health, and I really appreciate the talk we have just had, but I have more than 2 decades, it's touching nearly more than that now, across 2 countries, 2 continents in both of the global hemispheres. So I thought that might give us a good perspective on the digitization of health that's happening, and that where perhaps Botswana and other lower and middle income countries sit in that journey. So for those of you who don't know where Botswana is in Southern Africa. It's a landlocked country surrounded by South Africa, Namibia, Zimbabwe, just touches onto Zambia as well. It's the size of France or the state of Texas, and has a population around 2.6 million. So a very low, densely populated country with a population density of about 5 per square kilometre. In recent years, there's been much more urbanisation, as with many lower middle income countries, and now 76% of the population is urban. We're a very young country with a median age of under 24, and an improving life expectancy now up to 70 years. This took quite a toll during the HIV pandemic, but now the life expectancy is starting to rise again. Another interesting note when we're thinking about planet and our environment, Botswana is the host of more than half the region's elephants, with more than 130,000 elephants sharing the land with us, and more than 1 million cattle. So I just wanted to talk a bit about the evolution of medical records, and I started my medical career with the Lloyd George records, which are the file on the left, those fat paper folders wedged full of all the notes, hospital records, and notes that we as doctors made. These started in 1911 and only were finally phased out in the early 2000s, I think around 2020. I was also part of the cohort of GPs responsible for summarising these notes and enabling the NHS to now have a digitised health record. This was a very painstaking process where you had to read, if possible, doctors' handwriting to see what had happened at that person throughout their life, make a summary of it, try and identify what were the key points, that these could then be added into very neat, tidy, computer-based summaries. We did also have I don't know what to call it, but not the beautiful Windows-based systems that we use now, but the very green text screens from the old versions of EMIS. So there was computerized records that we used to run alongside the paper record. But this box here would arrive on your desk when you started your day in the morning, and it was neatly ordered in the where you were going to see your patients. And as you can see, it was quite challenging sometimes to find what was relevant in that patient's story. Within Botswana, patients again have handheld paper records. Some of these are beautifully kept in hardback books, laminated with a very chronological order. Others arrive in lots of little pieces of paper carried around in a plastic bag. But the difference in Botswana to the UK is that the patients have always had handheld records. They've always owned their own medical record, whereas in the UK that's only now starting to happen with the NHS app and handheld records that we have digitally in the UK. on the right, this is what my desk looks like when I go back and do locum work in the UK, which I do to maintain my license to practice. You're sitting with 2, sometimes 3 computer screens which fill your desk. One of my most challenging aspects of going backwards and forwards to the UK is working out what is a new system in place. At the minute, I think we're running about 5 or 6 different programs looking at the e-health record, an online consultation platform, a text messaging and emailing system, integrated document records that are scanned in. These all connect to the lab results that come from the hospitals, the imaging that we do. Then we can link to the different pharmacies around the country. So it's a really fabulous system, but it's all driven by our screens. So we're very dependent on our screens. The other thing that happens is one thing does not work, you very quickly can't access anything else. And that's my biggest challenge when I go back. I take about half a day to make sure everything is still talking to each other and belongs to my identity card. One of the biggest challenges I had recently is that the desktop phone had got swallowed up by the computer and no longer existed. It had become an electronic phone system, but I wasn't able to log in, so I couldn't call anyone for help. I had to physically go and find a person to help. So I think some of those challenges that happen with IT, we as healthcare workers need to be well trained on that, and as do our patients if they're going to use the systems. So how ready is Botswana and maybe other Southern African or lower middle income countries ready for digital health? Most of this data is taken from Statistics Botswana, and we have very high mobile phone ownership of over 84%. But most of the smartphones are owned by people younger than 45. So again, we can see there are discrepancies as to who has what type of phones. And I think across Africa and around the rest of the world, mobile phone ownership has really exploded. And people didn't really go through that process of insisting on a landline to their house. They just went straight to mobile phones. So I'm hoping that some of that rapid step where we're willing to embrace technology could also help with some of the other digital health things we're trying to use. Internet access is not as good as the mobile network coverage. And despite the very large areas of nature reserves we have in Botswana, there is more than a 90% country coverage with cell phone signal, which is actually much better on those very old Nokia phones than your smartphone. However, internet access is much more limited in rural areas, down at 23%, whereas the urban population has about a 79% use of internet. Most of that is used through phones. So mobile broadband accounts for 86%. Home-based internet is actually relatively expensive in Botswana compared to the UK and Europe. On this map, although it's looking more at the type of land area, the green areas situated in Gaborone, which is the capital, and Molopololi, this is the southeastern district, which accounts for 47% of the population of Botswana, giving us a population density of 14 per kilometre square. Again, still quite low compared to many other countries. And 39% of the rest of the country sit up in this Gaborone, Mahalape, up to Francistown, the second city. So you can see most of the population sit in the eastern side of the country. The rest of the country is much more sparsely populated. Although Botswana is now a lower middle income country, we have unfortunately a very high health and wealth inequality index, and that will of course affect some people's access to technology. I think some of the benefits of digital health and digitizing records are well documented, but I'll just reflect on my thoughts on that. I think the legible writing, very clear patient summaries, so it's very clear when you open your screen to see what are the known medical conditions with this patient, what is the prescribing history of drugs, and when did they have certain prescriptions, what are the drug interactions. The computers are brilliant at doing this. Looking at lab and imaging results and also graphic trends, monitoring blood pressure, looking at CD4 and viral load in HIV management, monitoring chronic kidney diseases. Those are really well placed in computerized digital computer records. Ongoing integration with social care records and hospital records, again, gives us a broader sense of one record that belongs to that patient. Computers are excellent at data analysis, much better than we, or most of us as humans are. They're brilliant at setting patient reminders for when your medication review is due. Are you due a blood test? During the COVID pandemic, they also helped with the immunization campaign for the different age groups and recall for cervical cancer screening, bowel cancer screening reminders. So the computer does a really excellent job at that. It's also very good at looking at if you're ordering your medication appropriately, is there compliance with medications? So I think the computer has a lot of use without detracting from how it benefits the patients. What are some of the challenges with digital records? Now, some of these are more likely to be challenges in lower resource settings, but they can be challenges within higher income countries too. So I think for us, the most obvious is whether we have reliable access to power and internet. Power outages are not uncommon across Southern Africa and are likely to get worse unless we upgrade our power structure and have different access to renewable resources. We have intermittent internet and sometimes the bandwidth is not great. So even though we have meetings around, for doctors around the country, we often don't have videos on. We find it harder to connect with each other, and that would be challenging with video consultations for patients. The other problem is access to affordable systems. The fabulous systems that we are able to use in the UK are just not affordable in a lower resource setting. And I know because I've looked at trying to get them brought here, but the cost is just not at all manageable. And I think moving forward, if you want equitable digital health, that is something that should be addressed at a global level and not just at the in-country level. You also need modern IT equipment to run these powerful systems. So the older computers, slower processing chips, cloud-based access to your health records really don't work unless you've got a good internet and a good processing speed. The other thing that happens is many individual practitioners in private care and in government have multiple different systems, becomes very fragmented. They don't talk very well to each other. Those are, again, less useful for the patient and for us as healthcare providers. I've touched a little bit about equitable access, particularly in the global south, where we are far behind access to some of these digital records and digital technologies that we hear about, the sort of continuous glucose monitoring, smartwatches, people accessing their records to update with technology that could help us as clinicians to manage them. The reminders for health checks, again, whilst very important, they can detract from the consultation with our patients. So often they sit up in a pop-up screen down to the lower end of the healthcare record, sit as reminders. Have you asked for smoking? When did you last do a blood pressure? BP is out of range. Do a diabetic foot check? Have you done a mental health review? So these sort of constant reminders sit there in the background of our very short 10-minute consultation with our patients. So are they really useful, or do they actually detract from the consultation that we have? And how do we fit them in? Again, in the UK, some of those quality and outcome frameworks affect your payment as a primary care provider. So if you don't do them, are you affecting your budget that you have then to care for your patients? Some of those, of course, are very relevant. It is important that we ask our patients, do they smoke? Have they tried to give up? It's just how do we fit them in, and how do we make sure that our consultation doesn't become doctor-driven and remains patient-driven? Some of the templates that are set up within these digital systems, for example, if you type in somebody's temperature or blood pressure that is out of range, it will set an alert up saying sepsis template, do you want to run this template? And it will prompt us to remember to look for other markers or identifying factors that would help us to decide, is the patient sitting in front of us septic? Do we need to take further action? And whilst these are good, they sometimes override clinician experience or really what the patient has come in for. So again, looking at, do those templates really help us? And where did the data come from in helping us devise these templates. Much of this data does not reflect the patients that we see within our African population. They're very much based on European and North American data, and some of this is very well known. For example, that Framingham cardiovascular risk score is not particularly accurate in certain populations. So moving forward, how do we make sure that everybody is represented in these template-driven health modelings? And the same is true of the increased use of AI. How is AI collecting its data, and from whom? Will it do the same thing? Will it leave out certain groups of the population, or will the data not be reflective of that group of people? When you have reports flashing up frequently, one of the key ones I think in the UK at the minute is the statin use. Do we over-medicalise patients? You know, if your cholesterol is high, but you are a 96-year-old who walks into the clinic unaided on no medication, do you really need to be on a statin, or is that just a data entry point to keep our records happy? So I think sometimes they tend to push us towards over-medicalisation. And are they really patient-centred? And that's where we as family physicians come in, try to match what the records are telling us to do to what our patients are needing. A little bit about remote consultations. So we touched a bit about saving travel time and reducing the carbon impact of that. Interestingly, remote consultations have been talked about for many, many years in the UK, but there were lots of reasons why they were thought not to be helpful, or there are lots of risks attached with them. But of course, during the COVID pandemic, we very quickly switched to almost 100% remote consultations, particularly in primary care. And despite being many years past COVID now, still about 33 to 35% of consultations with your GP are done remotely. 25% of those are done on the telephone, and about 8 or 9% done through text messaging and emails. So that we haven't completely undone or we haven't gone back to our pre-COVID era. We found a lot of use in some of those remote consultations. Lots of patients do still prefer face-to-face appointments if they could choose. Many patients prefer the reduced travel time to the clinic, not needing to take a full day off work, particularly in Botswana, where some of our population lives very far away, or might have to travel all the way to the capital city. That obviously has significant cost implications for people needing to travel far, and remote consultations may be a good use of our time. It may give you access to specialist opinions. Most of the hospital-based specialists are based here in the capital city, a few up in the second city, Francistown, and an even fewer number up in Maun, the third city. But really the hospital-based specialist care is very much capital city based. So rather than somebody coming all the way to be told, oh, you didn't need to come, having a remote consultation prior to that could be a useful tool. We've also used this for mentorship, particularly for our young doctors who are often posted in rural areas without significant colleague backup. So I think there are important benefits with remote consultations. What about the challenges to that? And again, there are often ways around this, but one of the main challenges is equitable access to technology. As we saw in one of the earlier slides, a large amount of the rural population do not have access to smartphones, do not have broadband internet, so would lack the opportunity to choose to have remote consultations should they desire. Now, there may be ways around that perhaps at their local health post, there could be an internet set up allowing them to communicate with doctors in a further town. So there are ways around it, but it just requires a bit more thinking. One of the other important things is about confidentiality and who is in the room with that patient. When we see our patients physically in the clinic, it's very clear who is there. And if there are other people coming in with that patient, we ask, who are you? And is the patient happy to have that person in the room? These have issues, particularly with gender-based violence. Is the patient safe at home to discuss the issues that they want when other people may be in the house? Are you able to take yourself to a quiet space where you can have a confidential consultation with your healthcare provider? And for some people, that may not be possible. When, again, a very long time ago, when I did my obstetrics job, was still paper-based records, the women would come with their antenatal cards, and in the bathroom where they had to go and provide a urine sample, on the back of the door in a paper folder was some stickers with a big notice saying, if you are at risk of domestic violence or you wish to speak to a healthcare worker alone, put a sticker on your notes. So that was very clever and hidden message, enabling women to discreetly ask for help without putting themselves at risk with their partner. We don't have any ways of doing that within the digital space that I'm aware of. Women attending child immunisation clinics, again, have access to healthcare workers, even though they've come with their child, gives them an opportunity to ask about their own issues. Some young people may not have access to their own phone or may have to use their parents' phone. So is that safe for them to receive text messages or help about sexual health, drug or alcohol abuse, mental health issues, if they're now needing to use somebody else's phone? There are some vulnerable groups who really do benefit from in-person care. Mental health, now there's either way with this. Some people do prefer having access to telephone consultations. It saves them the anxiety of attending the clinic. So many patients I've dealt with have actually preferred a telephone consultation rather than coming into the clinic. But it also means you don't have the opportunity to assess for other physical health options. Patients with dementia or other cognitive impairment may struggle to use remote consultations either with or without help. Palliative care, some of that can be done remotely, particularly in adjusting medication and providing ongoing support for family members. But having somebody physically present is very important for that. Gender-based violence and adolescence, we've already talked about. We also may miss relevant non-verbal cues that even on video consultation may not be so easy to pick up. We lose really the social context. Who else exists within this family? Who brought the patient to the clinic? Did the person have any difficulty getting out of the chair? How long did it take them to get in and out of the room or on and off the couch? So we miss some of those clues that we wouldn't pick up if we just speak to people sitting on their chair at home. What about beyond the screen? So again, we are primarily a patient-focused group of people. That's why we went into family medicine. And although the screen now takes up a wide space on our desk, it does not need to dictate or dominate our consultations. We have to find ways around using it. We have to find ways of using the digital information for our benefit and our patients' benefit, but still focusing on our face-to-face contact. We have to make sure that as family physicians, we remain community-based. We are trusted health providers and people do come to us asking for opinions. We have valuable knowledge about our local communities and the family context in which people belong. And these are not always easily picked up within a digital health record. We know if the carer of an elderly person has been admitted to hospital, if they're also our patient. We know if somebody's had a recent bereavement or had a childhood loss. We know whether there's a family member who's struggling with drug and alcohol issues. These are things that we learn by having continuity of care with our patients that are often not picked up in digital health records. We also act as somebody who can bridge the inequality gap. In people who don't have access to technology, who may not have a voice to use it, we can be that person. So our main aim really is caring for our patients. As family physicians, we are very good at adapting to different things that come along, finding new ways around things, and technology is just one of those other things that we have to learn and adapt with it. We should really ensure that there's equitable global access. And I think that's really important as we look at these huge advances in AI and in digital technology, robotic surgery, remote monitoring tools. Where are they within the context of the majority of the world's population? So I think if we don't address that, again, we just increase inequity. As discussed before, we should ensure that our AI and template modelling is very relevant to our communities and actually reflects the patients and people that we serve. And as family physicians, we really remain the coordinator, advisor, interpreter and guide for our patients. What do I mean by that? Patients come to us for advice. So they I think back again, before easy access to the internet, people would come with pieces of paper cut out from the newspaper, or something they'd heard on the news or a TV show about risk of breast cancer and HRT, or worry about MMR immunization, or worried about alcohol that they'd seen on an advert. So that hasn't really changed. People come to us asking for our views and our interpretation of health data. What is happening now is the patients are much more able to access information from their own home. There's a huge amount of information overload, and often lots of misrepresentation of facts or fake news. Again, we saw that very well represented during the COVID pandemic. So we act as a filter to that, as a guide to that, and help people make sense of the information they've given and how is it relevant to their setting. As family physicians, we also have a role for caring for our planet. So we should advocate for the use of technology that helps to mitigate, not worsen, climate change. We should encourage countries and companies who are using AI and AI, but well, yes, AI, that's a big use of power, using more and more digital technologies to actually use renewable power sources for that. We should advocate more for preventative medicine so that we manage appropriate prescribing, that we manage cost-effective care, which we do as primary health care, and even our lifestyle approach to many of our non-communicable diseases have significant benefits on the planet. For example, moving more to a plant-based diet, avoiding smoking and alcohol, encouraging more walking. These things have impact on our planet, but that weight should not sit entirely with the patient. So my one last slide is to warmly invite you all to Botswana in September for the 9th WONCA Africa Region Conference, which has a theme about planet health. So we are one Africa united to advance planetary health through collaboration and resource alignment in primary care. So I hope to see some of you then. Thank you.
Thank you, Claire, for that very interesting presentation. I mean, you discussed about the pros and cons of digital health, and with a family physician's eye, you discussed how to sort of use digital health in a way that is appropriate, and how also you discussed how to go ahead with the digital health, as well as about the care for planet as well as our patients. So thank you for that, and definitely we loved your pictures. They were very interesting.
That's to encourage you to Botswana so that you come and visit us.
I knew that you would put the last slide anyway. Okay, so let's discuss about. We have some questions. Okay, so Gabby, would you like to talk about some of the points that have been already raised on the chat? I know that you have already replied to some of them, but I would like to ask about these large language models and using some of these sort of technologies, digital technologies, and how to balance and how to think if you are a sort of a planetary health guy, and if you want to balance the harm versus, let's say, the opportunities that we have. What do you think about that? I think one of the things that you have already told is whether there's any other way of doing it. So go ahead. So can you?
Yeah, it'd be interesting to hear what Claire has to say about this as well. I normally say I don't like this imposition of feeling worried or morally anxious that you need to think about the environmental impacts. I would argue that this anxiety that we feel about trying to do it right while being a planetary health expert is put on us because of the neoliberal societies in which we live. And that actually, if we want to really think about caring for the planet, and you look at the care literature and the care ethics literature, ethics of care, then caring should not be something that causes anxiety. So caring is reciprocity. and it brings benefits to both the person that you are caring for, but also the person that is doing the caring. So this idea that you're feeling worried and stressed about what you should do suggests that this isn't something that is about caring, but is something that has created in neoliberal society. And so therefore, if you say, okay, well, I think one of the ideas in the chat was to develop an app. My first question would be, why are you developing the app? What is your end purpose? So you should have an end goal, and then that end goal is, how do I get to that end goal? And it might be through the development of an app, or it might be some other way that is more suitable or less harmful in various ways. But if it isn't, if the app is the best way and it is an LLM, go for it. If you're trying to produce value in society, then you go for it. And if there's, there are certain things you can do. I was talking about asking questions and, as much as you can, try and make sure that the data center you're using is using renewable energies by asking the question. If you can't, if you're in a country where there's only fossil fuels, then so be it, right? Asking the question is all you can do. So I would really step away from this idea that you should feel anxious for doing anything. I'll give you an example where I started to get worried. I had someone contact me through King's, and she was a hospital worker in the DRC. And she said, I want to have a chat with you because everybody is using AI and I want to use it. And I said, well, where are you? She says, I'm in the DRC, and we don't have a huge amount of money, but everyone's talking about how amazing AI is. What can I use it for? I was like, okay, should we just take a step back and see what the problem is first? Okay, is there a problem or an issue that you're trying to solve? Then we can work backwards and see if there is, AI is useful. I mean, let's not withstand that AI, in DRC has so many issues related to having no infrastructure and raising so many inequity issues that would emerge. The fact that she was trying to take a technology and push it onto a hospital in a country that was a low resource setting was hugely problematic. So it's about turning the narrative around and saying, what am I trying to do here? What is my main goal? If LLMs are the best way to do that, fine, but let me just check that they are first.
Fantastic. I think that's the best thing I heard today, because it's all about whether it's the best way to do, and whether the whatever the benefit would override the harm. That's it. Okay, so we have a lot of questions, and okay, Gabby, what do you think about e-waste? What is your take on that?
Again, I see e-waste as the result of very colonial capitalist structures in the sense that we have so much electronic waste, which is e-waste. I mean, e-waste includes computers and digital, but it includes other electronic waste as well. But if we focus on just digital, the problem is that as we increasingly improve the efficiency of our computers, we need to buy new computers. And not only that, but big tech feeds in planned obsolescence into the technologies that we have, which mean they plan these computers and laptops and phones to break in less short, like a time span than needed. So therefore we're replacing more often. So the electronic waste, there are many, many regulations around electronic waste, not least the Basel Convention, and many countries are now having regulations about not importing e-waste into their countries when high income countries are trying to get rid of it. But there are many loopholes. So if you can reuse the computer, then you can ship it to other low and middle income countries. But then what happens is that these countries get these computers and they use them, but the use of those technologies is very short because they've already been used. So they're turning over those technologies very, very quickly. That's one problem. And the other problem is that there's no regulations around what it means to have a safe, repurposed technology. And so, for example, my colleague who lives in Kenya said, I'm trying to be really sustainable. I bought a repurposed computer. I had to buy 3 in a year, because there are no standards. Whereas in the UK, I know that there are standards and guarantees. So here we start to see the differences in what it means to have e-waste. And then you have countries that are processing this e-waste in a non-regulated way, which means that communities come to recycle informally this e-waste through burning acids. And you probably know this, using acid baths, which causes massive amounts of environmental harm and health harm. And the solution is, well, let's just regulate these industries. But that regulation is really problematic in and of itself for a whole range of reasons. And because they tried to do it in Ghana, they flattened an e-waste community, one of the biggest in the world. But what we're seeing now is that they're just coming up black market. All the communities are starting again. We're seeing in India that they're regulating as much as possible, and that's working really well. But actually, what it's doing is forcing a lot of informal workers into capitalist endeavors where they didn't really want to be, which is affecting their livelihoods and putting pressure on them because they can't afford their premises and various other things. And so regulation isn't necessarily a solution. So there's a lot that needs to be figured out in a much broader capacity when we think about e-waste. The best we can do is try and use our computers until they die, and to take the philosophy that you should be proud to have the oldest computer in the room, not the youngest computer in the room. Claire, I didn't got anything to add to that.
Yeah, no, I think that's very important. That's why I couldn't link into sharing my video, because my 10-year-old computer finally died and I had to buy a new one. There was a comment about increasing blackouts that I just wanted to add on. One day last year when I was working in the UK, there was a computer outage where power was on, but all of the NHS system completely ground to a halt. So there was mass panic in the middle of a busy morning. When I go back and locum, I work in a 10-doctor practice, so we have a huge volume of patients that come through. And then we were like, well, what can we do? Even the phones don't work because, as I said, they've now bolted themselves into the computer. I said, well, the patients know who they're coming to see. The patients know their appointment time. So somebody just needs to stand in reception and write the name down of the patient, who they're seeing and the time, and tick them off. And the patient will find their way to the doctor. You can still have a consultation. But even finding a pen and paper was difficult because they have sort of confidentiality policy where you don't leave pieces of paper around. You don't write people's names on a piece of paper. So my sort of Botswana setting where, oh, there's no power again, we just go back to the paper notes, was very uncomfortable for lots of the doctors there, because we're so used to seeing everything handed to us on the computer screen. We actually forget a lot of the story sits inside us. The patients we know their stories way beyond what's written in their patient record. And I think some of the data looking at AI transcripts has reflected that. The doctors don't feel it is actually a true representation of what they would choose to remember from the consultation. It records enormous volumes of chat, but the few key points are missed. And some of those things that we know about our patients are not necessarily recorded in the record. So I think we really forget the power we have as primary care doctors in knowing our patients and knowing their settings and the clinical skills we have. We can take a history and examine a patient and think about what we might want to do next without a computer on. That's what we trained for. So we have somehow become over dependent on that and have lost some of our thinking skills and our ability to work as a patient-centered doctor when we hand it all back over to the computer. So I'm not sure that moving completely back to paper records is a good idea. I would love to be more digital in Botswana, but I think those are key things. If there are big internet outages or power issues, when you've put everything into the cloud, you are suddenly left with not very much. You have to think about how we would manage that.
I think that worries me the most, Claire, this idea that doctors become so reliant on data that they won't be looking at me, even as a patient, right, in that way. There's a primary care academic called Trish Greenlaw in the UK. You might know her, Claire, I don't know. You know her, right? She did a fantastic.
She's a North London person, yeah.
Actually, yeah. So she did a fantastic presentation for the Centre for Personalised Medicine, and I dropped the link in the chat. If you scroll through, guys, then you can see it. And she was specifically looking at this relationship between how do we navigate. We need loads of data, but also we need to focus on the patient. And she was talking about the need for both. But she's a great storyteller if nobody's ever heard her speak. So I encourage people to listen to her.
Thank you.
Regarding these blackouts, I have first-hand experience about it because in 2022, in Sri Lanka, we had this economic crisis and we didn't have dollars to buy fuel. So we had a lot of problems due to that. So we had no internet and we really felt how the future would be. So, I mean, it's not a not. I mean, what we thought was like, even though we are just thinking about the of the homos and what would happen next, but we have already experienced that. So, yes, we can think about that, especially in the LMICs. I saw that something about Mexico. Gabby, you have told about
Yeah.
blackouts in Mexico. Yeah.
Well, I mean, blackouts are happening everywhere. So, for example, we had one in the UK. Claire, you might know more about it. I think it was Guy's or St Thomas's, or one of the where the data center in the hospital, because of the heat wave in
Mm.
London, the data center crashed out and burned. So they didn't have access to data. But we're seeing that more and more and more. And with climate change, because data centers need to keep cool, I think that's going to become an increasing problem. In Mexico, in Mexico, they're starting to build data centers. I'm not sure what the agreement is between Trump and Mexico, to be honest, but they're building data centers and they're draining. There's certainly some places where they're draining so much energy that they drained energy from the hospital or from GPs practices, which ended up meaning that patients can access the GP. They couldn't get to go to hospital. I think that there was a lot of patients that ended up being quite sick because they couldn't access the electricity needed to be treated. And so there is this evidence that's starting to build where it is affecting healthcare and health workers and patients. And I think the biggest issue with data centers more than any other industry is that the environmental impacts are localized. So whereas other industries, they're being more broad, what you'll find with data centers is they're all built in like one area. So like Ireland, I think, which was mentioned in the chat, I think it's like over somebody, if you're in Ireland, you'll know more than me, but like astonishingly, like 20% or more electricity is just data centers, where you might have a country where it's zero. And so these localized aspects become very pronounced in relation to water and electricity. And that's what we need to be careful of, particularly as low middle income countries are being driven to invest in data centers and AI. So how do we make sure that when we do that, that we can protect our patient populations in those communities, like the communities that Claire was talking about, that they have enough water to implement wash and that they can wash their hands, and that data centers aren't taking that away from them, and all other issues that, come with that.
And I think in our
Yep, good. Yep.
in our clinic, we actually put solar panels on to act as our sort of backup power supply and as our primary power source. We still connect to the grid, but I mean that has helped a lot in our energy usage. But unfortunately, it doesn't completely help us, because if the internet is down, that's not within our system, that's somewhere else. So you might have a power cut where the I'm not very good at all the technology stuff. But anyway, where the internet provider is
Where the data
running your
center is located.
yes, and then it doesn't matter that you've got your lights on in your clinic, your internet is down. Now we can of course switch to mobile internet and dongles, and we have a wide range of those options. But I think it's not straightforward, which even if you think you're safe within your own power setup, it depends what's connecting. And as you showed, Gabby, all those internet cables dragging across the bottom of the world, it wouldn't take very much to disrupt that would have quite significant impacts on how we all communicate with each other, like in this meeting, and how we then access our health records.
And I think we'll see this more and more, this idea, because I think like cybersecurity and cyber hacking, like I know we're seeing it in the UK, like the NHS is being hacked, but Claire, like literally, I remember talking to somebody in digital sustainability, and he's saying, I got asked to come in and like do a pretend hack to see if I could access, I think it was for surveillance systems in the UK. And he's like, I just said to them, you know what? I don't need to do that. I can just walk around your perimeter and cut your cable. That is what I need to do. And there have been instances of this happening. And I think more and more as we rely on data, that's all you need to do is cut a cable, and then you've sent a lot of people out. So I think it's how to protect communities, how to protect health, and how to build resilience while also slowly bringing in digital in a way that I suppose is balanced, right? Not going too ho-ha, because that's when you get the inequities and the digital divide.
I have to acknowledge that we have our executive members, some of them here. Enrique is there, Alan is there. Both of them are past chairs, and also we have Andrew, our Europe lead. Colleagues, do you have any other questions specifically to be asked from Gabby or Claire? or you can just, Enrique, do you have anything else to add?
Excellent presentation. Thank you very much. Congrats, Sankha, for organizing this.
Hi, Andre. Thank you for joining on the way, I guess. Claire, I'll just ask a very simple question now with regarding telemedicine now and online consultations. How would you suggest to keep our compassion while doing an online consultation? Because all these communication skills would not sometimes work what we have learned or practiced in a physical consultation, in an online consultation. How would you suggest to go ahead in an online consultation to? Yep.
That's a great question, Sank, and I'm sure I don't have all the answers to that. I think from my own experience, what I try to do is ask one simple question at a time and allow a longer pause than you would normally do in terms of a face-to-face consultation, particularly if there isn't video. So if you're just having a phone call, then actually allowing space, asking a very clear question. And again, sticking back to our principles about what do you think about that? What would you like to ask me about that? So again, putting it back to let the patient do more of the talking, and then that feels more like a chat they would have on the phone with a family member or a friend. So I think the principles of our consultation skills remain the same, but maybe some small changes in how we allow a longer pause, or how we might sometimes choose to interrupt a patient because we've lost the visual clues when somebody chooses to talk for 20 minutes and we need to cut them off a little bit. You have to find ways of how do we interrupt in a polite way so that we try to ask the information that's relevant. So I think there's not a huge difference in our consultation styles. Speaking a little bit slower, allowing more space for the patient to answer.
And Clara, now I think you worked in while you were working in the UK. I think you have experienced both paper-based record era as well as electronic era. Is that so? Because I have never seen papers in the UK when I was there. So it's like,
I know that's what I was saying. I was showing my age, but yeah, the Lloyd George notes were still very much in practice when I first started working as a GP in 2004. And then in the 2 or 3 years after that, we were physically, I'm sure you're not allowed to do this now, but taking sets of notes home and summarizing, 5 or 10 files per night. I probably shouldn't say that. But anyway, and then taking them back to the clinic. And then we had a data entry clerk who was looking at our 1-page summary to literally add that into the screen. So in the early 2000s, there was some funds set aside from the government to help digitize the records. Many practices still have the Lloyd George in storage, but actually more of that has moved to off-site storage now, and they're stored at secure, fireproof spaces, and they're in the process of being scanned and I think read by AI to then be added into the system, so they won't be completely destroyed. But it's actually quite nice seeing some of the very old, beautiful fountain pen writing, some of it completely illegible, coffee stains on the cups, and sometimes rammed into there. So very, very difficult to find the pieces of information. I think that is the biggest challenge with that handheld, paper-based records, isn't it? How do you keep them in a good order? And certainly in Botswana, I've used the summary sheets like we see on our electronic records in the UK, and I've actually printed one of those off to then fill in for our patients, because some of our patients have 20 years of HIV care, so they have very, very fat files with huge amounts of results, lots of interesting health conditions that have followed them through that journey of HIV, and you can't possibly look at that when you have a short time with the patient. So having a brief, even if you've got paper notes, having a summary sheet at the beginning is really key to helping us as doctors if the patients are new to us, but also reminding us if they're patients we haven't seen for a while. So I nag my colleagues a little bit about trying to update that summary sheet.
So when you were like working with these paper-based records, and then when it switched to the electronic records, so what were the challenges you had? I mean, how do you perceive the care, the aspect of care, or the probably the GPs? I mean, as GPs, the real care that we provide. How did it change? What do you think about that?
Yeah, I think in that initial change over time, there was a computer record, but like I said, it was that old green text, very, very brief. You wrote one or two very brief words in it. Most of it was in the computer. So for a long time, we were running on this dual system, which is really inefficient. We had a lot of training in, most GPs run on one of two systems, so sort of EMIS or System 1. And you had a lot of training before that sort of go live. You had a dummy system that was in place. You had to take time out of clinical work to learn the system. We actually had a trainer in the practice for the 3 weeks of the switchover. You had to reduce the number of patients you saw. There was somebody hovering outside, so if you got stuck on the computer part the way through the consultation, they would nip in and speak to you. So it really is a huge learning curve to become comfortable navigating around the record systems. And certainly now they're so much more complicated than when I took it on. I mean, the EMIS and System 1 have not changed considerably, but now all these add-ons with sort of e-consults and AccuRx and health things and prescribing, that's all bolted on. And I often find when I go back, I have half a day with the IT person saying, what is new? What have you done since I last left? Because when you start your morning clinic at 10-minute appointments, you can't really spend time now saying, I can't do a prescription because I can't send it to your pharmacy. So I think it's really that's the biggest challenge, I think, in upgrading our skills. And like everything, once you get used to using something, it becomes second nature, and we become more efficient. We become more efficient at doing it. And again, in trying to type whilst talking to the patient, so you haven't got the screen sitting between you and the patient is really key. But sometimes if you've got a very complicated story from the patient, trying to document that whilst listening in a compassionate and empathic way is also very challenging. It looks rude if you have your back to the patient and say, hold on, trying to type. That does break our communication. I'm sure there are others in this group that have thoughts on that as well.
You can just unmute yourself and talk, because we don't have a lot of people at the moment, so we can of course have a or any other questions or any other comments. A lot of comments and replies on chat. I think Gabby had answered almost everything. Good. Okay. I think we had a very fruitful discussion. Thank you both, Gabby and Claire, for your time despite your busy schedules. I know Gabby just finished her work and joined us. Thank you very much, Gabby and Claire, amidst your busy schedule. So, colleagues, we all, I mean, most of us except Gabby, are family doctors who are with our patients, and we always want, as one of the major quality or value, a principle of family medicine, we extend a compassionate care, the comprehensive care and continuity of care to our patients. And definitely, the digital health is inevitable, and we definitely understand that it gives us more opportunities. And I think it is a very good, important tool to extend our care to our patients. But we discussed how we should utilize it in a way that we can still retain the compassionate care that always govern our discipline, family medicine or general practice. So thank you very much, speakers, and thank you very much, everyone who joined today. We have recorded this discussion, and it will be available on WONCA YouTube soon. And thank you, Anna, for your simultaneous Spanish translations. And see you all. Happy Family Doctor Day, and have a good day.